Hi guys, welcome to Podcast Med. In this video or podcast, I'm going to be discussing about organophosphate poisoning. Organophosphate poisoning or OP poisoning is the most common poisoning that we see in Southeast Asian countries, and it is the most common poisoning or emergency case that we see in OPDs of medicine. And coming to the compounds which cause organophosphate poisoning, we have three classes of compounds in that. Those are nerve gases, dichlorocompounds, diethyl compounds. Under nerve gases, we have taboon, sarin, soman, cyclosarin. Under dichlorocompounds, we have parathion, malathion, dichlorophos, methamidofos. And under diethyl compounds, we have chlorodiphos, diagenon. After this, we'll be discussing about the route of administration. The route of administration of poisoning. How can it happen? It can happen through three routes. That is mainly by orally. Orally, if someone drinks up the fertilizer pesticide which contains organophosphate compounds, they will end up in poisoning or OP poisoning. Or it can also be due to respiratory exposure, where when someone is spraying pesticides in the fields, they will get exposed in a respiratory way, and as well as the organophosphates can dissolve dermally also. So like that, there is dermal absorption of organophosphate compounds as well. So these are the three routes of administration or routes of consumption of organophosphate compounds. And then we have stages of organophosphate poisoning. Before that, we should be discussing about pathophysiology of organophosphate poisoning. So it's nothing. Organophosphates will go. Those will irreversibly inactivate the acetylcholine esterase enzyme, which normally will convert acetylcholine into acetyl-CoA and choline, where choline goes back into the presynaptic membrane or nerve, and then it is recycled again. So when this is irreversibly inhibited, there is cholinergic toxicity near the synapses. So it causes cholinergic toxicity and cholinergic symptoms. We have three stages of clinical features in organophosphate poisoning. Firstly, acute cholinergic phase. Secondly, intermediate syndrome. Thirdly, delayed polyneuropathy. So, acute cholinergic phase starts within 1 hour and it lasts for 48 to 72 hours. Okay. In this stage of OP poisoning, we'll have muscarinic symptoms, nicotinic symptoms, CNS symptoms, cardiac symptoms, and respiratory symptoms. Under muscarinic symptoms, we have a mnemonic for this, that is sludge BBM. Okay, sludge, SLUDGE Okay, sludge means salivation, lacrimation, urination, defecation, gastric emesis, gastric emesis, bronchoria, bradycardia, meiosis. This organophosphate poisoning in this also can cause tachycardia and hypertension if sympathetic stimulation happens for temporary time, like for temporarily. And then after muscarinic symptoms, we will go with the nicotinic symptoms. Nicotinic symptoms under this are muscle twitching, fasciculations, weakness, respiratory paralysis, hypertension, and tachycardia. These are nicotinic symptoms here actually. And coming to the CNS symptoms, that is central nervous system symptoms, we'll have central respiratory depression, anxiety, restlessness, weakness, confusion, convulsions, coma. Under cardiac symptoms, we can have heart blocks, arrhythmias, QTc prolongation. And under respiratory, we have respiratory paralysis and other respiratory symptoms, where respiratory paralysis is the most common cause of death here. Then the second stage of OP poisoning is intermediate syndrome. It lasts from 48 hours, starts at 48 hours and lasts till 72 to 96 hours. There is marked muscle weakness here. The risk factors being exposure to highly fat-soluble organophosphates. This This stage will occur when there is exposure to highly fat-soluble OPs. Under the compounds that we have discussed there, highly fat-soluble organophosphates can cause this intermediate symptom, can lead till here, okay. We'll have the muscles involved in this are ocular muscles, neck muscles, proximal muscles of limbs, respiratory muscles as well. After this, there we have delayed polyneuropathy. Delayed polyneuropathy starts at 1 week and can go on till 3 weeks, 1 to 3 weeks maximum. It is a stage where there is degeneration of myelinated nerve fibers, and we can see loss of deep tendon reflexes. Symmetrical placid paralysis can be there. There can be rarely sensory loss also. So this is delayed polyneuropathy. So how can we diagnose the OP poisoning? Coming to that, we'll have pungent garlic smell coming from the patient. We have to take history. What did he consume? How did he take? We should ask all the details of consumption. If he is any suicidal or something like that, all of those things we have to ask. Or else, if we have to ask if he's spraying those pesticides in the fields for a long time without any protective equipment on the skin and respiratory tract. So that can also cause respiratory and dermal absorption of organophosphates. All of those we can ask and then rule out the causes. There will be all these muscarinic nicotinic symptoms over here. And one more thing is there is meiosis, that is constriction of pupils seen here. And it shouldn't be confused with a morphine poisoning, where morphine poisoning will have pinpoint pupil. Then after that, we'll go with the toxicological analysis of blood, gastric secretions, urine, etc. After that, we'll also do serum pseudocholinesterase level testing, like if they will be decreased in the blood because of this. Then after diagnosis, coming to the management, firstly we have to remove the person from the exposure. Okay, we have to remove the person from the exposure, like removing the clothes, cleaning the body, like washing the body properly if there is dermal absorption of OPs. Then we'll do gastric lavage in oral poisoning cases, which should be done within 1 hour for effectiveness. Then we'll send the sample for the toxicological analysis, and here induction of emesis is contraindicated. And then we can add the other things like activated charcoal, which we add 50 to 100 grams of it. Initially 4 hourly we'll be giving it until charcoal appears in the feces. Then after that we'll give the main antidote for OP poisoning, that is atropine. Atropine is infused intravenously. Initially we'll give 1 mg for test dose kind of. If he doesn't have any allergy towards it, we'll give it. After that we'll start with 2 mg of atropine per every 15 minutes and till the OP poisoning is reversed. The signs of reversal of OP poisoning or atropinization may be, or firstly this bronchospasm, bronchoria, bradycardia and hypotension. All of these 4 things will be reversed if the atropine is working. Then after that, till the patient develops atropinization, we should symptoms of atropinization, we should be giving atropine. What are the symptoms of atropinization? Are as follows. Here drying of secretions will be there, dry mouth, dilated pupil, tachycardia. All of this should happen to say if the patient is completely atropinized. Then normally in practical life there are 4 to without doing that 1 mg test dose at first, then if there is no adverse effects, we'll give 2 mg per 15 minutes normally according to the textbooks. But as far as our professor said, we give 4 to 5 ampoules of atropine. It is given infused into the body, and we'll be checking the vitals of the patient until his symptoms gets reversed and all the vitals get stabilized. And then we can also give glycopyrrolate, which is a muscarinic anticholinergic, and it won't even cross blood-brain barrier. So we'll give 1 ml injection, which will have 0.2 mg of glycopyrrolate. And after glycopyrrolate, we can give oximes here. Okay, they will reactivate the phosphorylated receptors. They will reactivate those receptors. What receptors? Acetylcholinesterase receptors. Okay. The pathophysiology that I've said over there, I said irreversible inactivation of acetylcholine esterase enzyme. It's not that. It is receptors. They will go sit on the receptors of acetylcholine esterase and won't allow its action. So there won't be there will be accumulation of acetylcholine in the cleft. Then, okay, coming to oximes, they reactivate the phosphorylated receptors. The oxime which we normally give is pralidoxime. 1 gram will give stat or 30 mg per stat 30 mg per kg in 100 ml normal saline IV over 30 minutes. So after this, we have to discuss one more point here, which is we give the infusion very slowly over 30 minutes to prevent cardiac arrests because of fast infusion. So this is it with the OP poisoning that I have read today. That's it.